Good morning, everyone. I think we'll start. We have about 90 plus people here. So, very good morning to everyone present here. We from the Department of Medicine, MSRMC Medical College, Bangalore, have come up with this interesting and innovative series called Deciphering the ECG. We aim to make it simplified and easy to understand to all the medicos out there so that learning ECG becomes fun and easy. It is an initiative by us, and we plan to hold it on every Sundays this entire month so that we can make the understanding of ECGs fun. So we'll begin today's, so I would like to thank the Department of Medicine for giving me this opportunity to give the introduction on basics of ECG. So we'll begin with the understanding of the heart. So a quote from Neil Tyson: "Know more today about the world than yesterday and lessen the suffering of others. You'd be surprised how far that gets you." So let's understand more about ECG and how we can help save lives. So these are the brief outline of what we would be covering in this class. So today we'll be covering about the basics of the electrophysiology, how the leads are oriented to the heart, how each wave in the ECG is generated, and how the ECG paper works, and how do we determine the axis and its importance, and what are the technical errors that we commonly encounter whenever we read ECGs, and what is the method to approach any reporting of any ECG. So for everything we need the basics. Just close your eyes and just imagine yourself inside the heart. Just feel your entire heartbeat. So it constantly beats every moment, every single second. From the day 21 of intrauterine life, it has constantly been beating every single moment up till now. This marvelous organ, what makes it beat constantly?
No separate shop.
So that is because of its ability to generate its own rhythm called as automaticity. So what gives the heart this automaticity? So it is the pacemaker of the heart. This pacemaker of the heart is the SA node, the sinoatrial node. So it sits in the right atrium, the posterior wall of the right atrium, and the impulse travels from the right atrium to the left atrium via an anterior fascicle called as the Bachmann's bundle, and from the Bachmann's bundle, the entire left atrium is activated. Once the right atrium is activated, and the entire atrium continuously is acting as a single pump or a single unit, which is called as a syncytium. That is the peculiarity of the cardiac muscle because it has something called as gap junctions through which the electrical impulse can pass from one cell to another cell. So once the entire atrium is activated, we have to remember that electrical activity and mechanical activity are two distinct entities. First, there is going to be an electrical activation. Following the electrical activation, there is going to be the mechanical activation or contraction. So once the entire atria is having positively charged, it is going to contract. If it is going to contract, the ventricle has to receive that amount of blood. So there is going to be ventricular diastole or relaxation. So the impulse reaches the AV node and has a physiological delay. Why is this delay important? Because it allows the entire left ventricle or both the ventricles to be filled with blood so that they can contract in the next contraction. So once we reach the AV node, it has two highways. These two highways are the left bundle branch and the right bundle branch. Traditionally, we are taught that the left bundle branch has two fascicles, the left anterior and the left posterior fascicle. But there have been a lot of evidences to state that there is the existence of a septal fascicle, and septal fascicular blocks have also been described. And the right bundle is a single bundle, and the left bundle has three fascicles, which is the septal, the anterior, and the posterior. So this is the similar that shows the left bundle dividing into a left anterior fascicle and the left and the left posterior fascicle, and the importance is the septal fascicle. And this is the chorda tendineae, beautifully seen, the fan-like structure here, attached to the papillary muscle. This is the posteromedial papillary muscle, this is the anterolateral papillary muscle. So we saw that the SA node has its ability to generate its own rhythm. That is because of something called as a pacemaker potential. So if you see the action potential in the cardiac nodal tissue, so there is peculiarity that the sodium channels here open whenever there is repolarization. So this is the phase of repolarization, and during this phase it gets activated. So that is why it generates a current called as a funny current. It's funny because the channel is opening when there is hyperpolarization or repolarization happening. And this funny current has its own implications. Once the cardiac resting membrane potential reaches somewhere about 40 to 45 millivolt, minus 40 to 45 millivolt, the calcium channel opens and there is rapid depolarization. So depolarization indicates there is increase in the positive charges. So once there is increase in the positive charges, the waveform spreads to the entire atria, and once the positive charges end, there is going to be a phase of repolarization so that we maintain electrical neutrality. And this cycle continues constantly. And very important thing is this phase 4 is called the pacemaker potential is also under the control of the sympathetic nervous system. So if we have any arrhythmia, so why should we know this is because we have drugs that can block the funny current, so called as ivabradine. So that is having an increasing use in the patients with heart failure. In heart failure, you reduce the heart rate by 5, you improve you reduce the mortality by 18%. So that is the importance of knowing this current. The funny current, you block that with ivabradine. The second thing is there are some kind of arrhythmias that are because of increased activation of the sympathetic system. So such sympathetic system blockade by beta blockers also are beneficial. So that is one more importance of knowing this action potential. Third importance to draw from this is all of these are calcium dependent. So calcium channel blockers work very well for nodal tissues, especially the SA node and the AV node. So once the electrical impulse arises and enters the myocyte, so this is the myocyte action potential. So there are 4 phases, 0, 1, 2, 3 and 4. Phase 4 is the resting membrane potential at minus 90 millivolt. Phase 0 is when there is rapid influx of sodium. Phase 1 is when there is efflux of potassium. Phase 2 is where there is a plateau phase wherein calcium and potassium balance each other. Phase 3 is when repolarization happens, and phase 4 the heart regains its resting membrane potential via sodium potassium ATPase. So let's correlate this with the ECG, whatever is happening. I'm sure we all know what are the basic waves. We'll see how each wave is generated and what are its importances. So phase 1, is my voice audible to everyone?
Yes, sir.
Audible.
So phase 0 is where we have the QRS complex that is generated. This QRS is phase 0, and phase 2 corresponds to predominantly the ST segment here. Phase 3 is predominantly correlating with the T wave, and phase 4 again is the TP segment. So what is the importance we draw from this? Very important is this phase 0. This phase 0 is correlating with the QRS. So if I have any drug that is going to increase the phase 0 in this manner, imagine this is the line I draw. So that means the QRS can widen. So sodium channel blockers, phase 1A blockers, sodium channel blockers, they widen the QRS. So whenever you have a wide QRS, you should also think of possibility of a tricyclic antidepressant toxicity. Usually they cause widening of the QRS. Coming to phase 2, with this action potential, you can understand what are the effects of electrolytes on the ECG. So phase 2 is predominantly by calcium and potassium. So if I have a hypocalcemia, I will affect predominantly the ST segment here. If I have a hypokalemia, it affects the phase 2 as well as phase 3. So I will have the affection of a ST segment as well as the T wave. So this is the importance of knowing this action potential. And this entire duration of this action potential correlates with the QT interval. You can see here, this is the onset of the Q wave, this is the end of the T wave. So this is the action potential duration, and this action potential duration is what correlates with the QT interval. Okay, so most of it are able to hear. I think it's all right. Okay, we'll proceed. Okay. So we know that pacemaker of the heart is the SA node. Why is it called as the dominant pacemaker? That is because the SA node is able to generate the heart rate at the highest, which is 60 to 100. We have the other pacemakers, which is if the SA node fails, the AV node will take over. If the AV node fails, we can have the Purkinje fibers and the ventricles take over. So SA node is called as the dominant pacemaker. Although all of these can generate the rhythm, they are also called as latent pacemakers. Because it generates at a very high rate, this high rate suppresses the activity of the AV node, the bundle of S, and the Purkinje fibers. That is why the spontaneous firing does not happen in this. So that mechanism is called as overdrive suppression. By increasing the rate, it is suppressing the other latent pacemakers. So what is the importance of knowing this? The intrinsic rate of beating of the SA node is 60 to 100. Whereas for the AV node, it is 40 to 60. Purkinje fibers, it is 20 to 30. Purkinje fibers correlate with the ventricular myocardium. So in case the impulse arises from the AV node, what is expected is the heart rate to be 40 to 60. If it is more than that or less than that, it means that there is some other pathology that is there that is causing this depression or overactivity. Similar with the ventricle. So ventricle, the intrinsic rate is supposed to be 20 to 40. So I'm sure we all have heard of ventricular tachycardia, where the ventricle shoots at about more than 100 beats per minute. So that is the condition is important to remember because it is the abnormality. The normal ventricle is supposed to beat only at 20 to 30 beats per minute. Importance, if the SA node is suppressed, the subsequent pacemakers take over. The subsequent pacemaker that takes over is called as the ectopic pacemaker. So just a recap of what I have told. So the applications of knowing the action potential are the beta blockers in the arrhythmias that are dependent upon the sympathetic nervous system, the IF current blocker, which is ivabradine, the effect of dyselectrolemia on the ECG, we have seen, whereas the sodium affects phase 0, phase 2 affected by calcium, 3 and 4 affected by potassium. And there are so many drugs that prolong the QT interval. We'll come to it subsequently. So with this basic understanding of what is the ECG and the electrical activity, so we'll enter inside what are leads. So leads are some electrodes that determine the direction of flow of current. So if this is the heart, so if this is my heart, I have to see the heart in an entire 360 degree. So if I have to see the heart in an entire 360 degree, I can divide the leads into a transverse plane and a coronal plane. So if I have to see the heart activity in the horizontal plane, I have few leads that I place anteriorly. If I want to see the heart's activity, in the coronal plane, I place it throughout the heart. So this way I get the 360 degree orientation of the heart, which is in the horizontal plane and in the coronal plane. So we can divide the leads into two types. One is called as the bipolar, one is called as a unipolar. Bipolar because there are 2 points of electrical difference that is there, that is noted in the lead, and the potential difference across that is measured. So bipolar leads are lead 1, 2 and 3. Whereas unipolar leads are all the rest, which are AVR, AVL and AVF and V1 to V6. We'll see what are those leads subsequently now. So the aim is to enable us to look at the electrical activity of the heart in both the planes. So before we start that, we have to understand this very important basics, which is how will the electrode pick up the signal. So if I have a wave which is positive, which is a depolarization. Depolarization means it is positively charged. So if a positively charged current is moving towards the electrode, it records a positive deflection. If a positively charged electrode, the current is moving away from a lead, it shows a negative deflection. Peculiar is whenever it is placed perpendicular. If the lead is placed perpendicular to this movement, then it shows a biphasic deflection. So you can remember it like this. So whenever someone is very happy and they come near us, we feel very happy. So we are positively charged. Whereas if your very close friend is going back to his home or to his hostel, then we feel sad, which is a negative deflection. Take the exact opposite. A sad, gloomy person comes to you. So you feel sad. So if a negatively charged wave comes towards me, I get a negative deflection. And if the same person goes away from you, you feel happy. So that is positive. So exact vice versa. So positively charged moving towards electrode is positive, and negatively charged electrode that is moving towards me will give a negative wave. So with this, we will see how the heart is going to pick up these electrical signals. So to understand that, we come to this very, very important law called as the Einthoven's triangle. So imagine the heart in the center, and we place two electrodes which we want to look at the electrical activity across the right arm and the left arm. So here, the electrical activity we saw here, how was the electrical activity moving? So in the atria, so once the electrical activity arises, the SA node initially activates the right atrium and then it activates the left atrium. So the net vector here, so the net direction of movement of current would be downwards and leftwards. So if we take that here, so the activity of current is initially in this direction as well as this direction. So if we have two arms, this is the right arm, this is the left arm. LA stands for the left arm, RA stands for the right arm. So importance is, so if we take the electrical activity of the atria here, if you are taking the electrical activity here, so we see that the electrical activity is moving in this direction. If it is going to move in this direction, it means that this lead will show a positive deflection. If the electrical activity is moving away, you will get a negative deflection. This is lead 1. So we have 3 leads here. Lead 1 is the difference between the right arm and the left arm. Lead 2 is the difference between the right arm and the left leg. And lead 3 is the difference between left arm and the left leg. So similarly, if the current is moving towards my left leg, that means I get a positive deflection. And if the current is moving away from my left leg, I get a negative deflection. Same with lead 3. So importance is, we know that the P wave, which is the measure of atrial depolarization, has to be positive in lead 1, lead 2, and lead 3. Because this electrode is moving in this direction, this is the net activity of the entire heart. If I place a vector, if I place a camera here, it will see that the activity is moving away. So that is why this part here is negative. So we'll come to the modifications of this lead. So this was the initial lead that Einthoven made, which is this is also called as the Einthoven's triangle. So once we know this Einthoven's triangle, there's a law, Einthoven's law, that states that lead 1 plus lead 3 should be equal to lead 2. We'll see what this means. This means that the sum of all the electrical activities in lead 1 and lead 3 will be equal to lead 2. Then there was one more person who said that let's take the midway or central electrical neutral point between all these 3 leads. So we will arrive at a point called as 0. This 0 was called as Wilson central terminal. This Wilson central terminal was modified further by Goldberger. Goldberger said, I'll take this point and I'll introduce 3 other electrodes. one across the left atrium, seeing the left atrium. So because it was seeing towards my left, so it was called as lead AVL. And towards my foot down, which is called as lead AVF. And one across the right side called as lead AVR. So this gave us a better understanding of the entire coronal plane of the heart. So if my electrical activity I have to tell, so my P wave, is going to be moving in this direction as well as leftward and downward. So that means, can anyone tell in the chat, can anyone reply in the chat, what will be the direction of AVR? Would it be positive or would it be negative? Yes. Okay, yes, correct.
Negative.
So it would be negative. So this is the importance of understanding this entire Einthoven's triangle. So any activity that is moving in this direction will always be positive and this would be negative. The very basic, or why should we know about all this, is because we have to imagine the heart in a 360 degree. So once we finish with the lead 1, 2 and 3, this was the augmented lead. So we see the electrical activity in AVR, we see the electrical activity in AVL and electrical activity in AVF. So it is directed downwards. So the electrical activity you see here, it's directed downward, here it is downward, directed towards the left, and this is towards the right. So these are the importance of these leads. Why it is called augmented? Because this is a unipolar lead. So that means it has only one point where it notices, which is, this is 0 and this is here. So to exemplify or amplify the signal, he connected these two together. So that's what Goldberger did. And this is called as an augmented lead. So if we know this, we have to know where should we place our lead. Okay. So because this is where everything matters. Although we know the theory of where each lead should be placed, everything, but if we don't place it properly, our entire interpretation will be wrong. So there are 4 leads whenever we have to consider in the limb leads. So one is at the left arm, left leg and right leg. So right foot is the neutral foot, which is black. Left is yellow, right is red, and left lower limb is green. It will usually be given in the machine, the ECG machine. So always make sure that you see that and then connect it. Otherwise, there will be gross mistakes that can happen in our interpretation as well. There can be lead misplacements. And coming to the precordial leads, very, very common. You go to any ward and you ask the sister to get an ECG, inevitably the V1, V2 is very highly placed somewhere in the second or third intercostal space. Very important is where should we place these leads. So if it's the manubrium sterni, reach the manubrium sterni and then count the intercostal space. From the manubrium sterni, the space would be corresponding to the second intercostal space. So you come down first, second, third and fourth. So place V1 in the right fourth intercostal space. Place V2 in the left fourth intercostal space. And coming to lead 4 is the next to be placed. Imagine the mid clavicular line. Place V4 there in the fifth intercostal space. And place V3 midway between V2 and V4. And again, take V6 in the anterior axillary line and place V5 in between V4 and V6. So this is the normal placement of the precordial leads. Can anyone tell what V stands for in the precordial leads? We say V1 to V6. So what does V stand for? You can take a guess. Ventral, someone says ventral, okay. Anyone else with any other answers? Voltage, very good. V stands for voltage, correct. So V stands for voltage, correct. It is a unipolar lead. All the precordial leads are unipolar and V stands for voltage. We are measuring voltage. So these are the routine leads. So with this, we have 6 leads that we get in the limb leads, and we have 6 leads which are the precordial or chest leads. So total we have 12 leads. So there are some modifications sometimes that we do. So that is called as the posterior leads. So very, very important is whenever we have an inferior wall MI, we also have to look at the posterior wall. So we just modify, we continue this V6 as V7, V8 and V9. We place those leads posteriorly. One in the mid-scapular line at V8, V7 and V9 beside that, adjacent to that. So routinely it is not commonly used, but the importance is to detect a posterior wall myocardial infarction if you are suspecting it. And whenever you're looking at ECGs, always look at leads in its continuity. So here we will see this part. So imagine this as my heart. So here, this is going to be my lateral surface. This is going to be my inferior surface. This is going to be towards my right, and this is going to be my precordial leads. So imagine this is my heart. So I have some leads that are going to see the electrical activity from below. There are some leads that are going to see the activity from the lateral side or towards the left. There are some leads that are going to see my electrical activity from above like this. So depending upon the direction of electrical activity, each of these are going to show specific changes. So this is what is we are supposed to imagine. That is the importance of knowing these leads. So always look at these leads in contiguity. So lead 2, 3 and AVF. We have 3 leads here, which are 2, 3 and AVF here. So these are called as the inferior leads because they are going to see my heart from the inferior surface. Here we have 4 leads. One is AVL and lead 1 and V5 and V6. This is called as the lateral wall of the heart. So these leads represent the lateral wall. And lead AVR looks at the right-sided activity. Also to some extent we can use V1 and V2 to look at the right-sided activity. V3, V4 are anterior leads. V5, V6 are exactly lateral leads. So whenever you are seeing an ECG, look always in this manner. So you look at inferior leads, look at lateral leads, 1 AVL, V5, V6. Then look at V1, V2, which is septal, V3, V4, which is anterior. And there is something called as a high lateral lead, wherein in some cases of a myocardial infarction, only lead 1 and AVL will show change, whereas V5, V6 is normal. So that is called as the high lateral wall. So this is the high lateral leads. So there is going to be an exclusive session on myocardial ischemia and infarction. That is going to be there. So always when you're looking at the ECG, look at as inferior leads, lateral leads, septal and anterior. So always a mental picture like this would make you understand what is exactly happening in the heart. So a recap of the same. Inferior leads 2, 3 AVF, lateral 1 AVL, V5, V6, anterior V3, V4, septal V1, V2. So this is the gist of understanding the heart of the leads. So once you have understood the leads, it is more easier to understand how each wave is going to be generated and how it will appear on each of these leads. So first we will begin with the atrial activity. So we see the SA node here that is going to generate the electrical activity. How it spreads is it is going to spread in this manner downward and leftward. Because it has to activate the left atrium, it moves leftward and it activates the AV node, so it is going to activate the AV node in this direction, which is downward. So this, if you are going to imagine this as my heart, so can someone tell me in which lead you are going to get a negative wave and in which lead you are going to get a positive wave? Correct? AVR is negative, very good. Excellent. So here we are seeing AVR, yes, correct. AVR is negative, very good. Lead 2 is positive, lead 1 is positive, AVR is negative, very good, very good, very good. So this is what we are seeing. So this entire activity is going to be negative in AVR and positive in lead 1. So this is the direction of lead 2 as well. We saw in the Einthoven triangle. So lead 2 will also be positive. Almost all the leads will be positive here except AVR, which will be negative. And because the initial portion is the right atrium that is first, so the first portion of the atria of the P wave, so this entire atrial activation is going to cause a wave called as a P wave. So we should know what is a normal P wave and we'll understand the components of the normal P wave. A normal P wave has two parts, which is the initial 1/3 or 2/3 is represented by the right atrial activity because it is initially activating the right atrium and then spreads to the left atrium and activates the left atrium. So this entire duration here should be, you can remember as 2.5. So the height of the P wave here should be 2.5 and the width also should be 2.5. It should be less than 2.5 millimeter. If it exceeds it, it means there is excess activity in the atria. One more important thing is, we'll come to it. So P wave represents an atrial depolarization. It helps in identifying the origin of the pacemaker. Very important to note that SA node activity is silent on the ECG. SA node activity cannot be picked up on the ECG. It is the atrial activity which we use as a surrogate of the SA nodal activity because the SA node lies very close in the right atrium. SA node is very silent and it needs intracardiac ECGs. So it is upright in 1, 2, AVF, V4 and V6. It is biphasic in V1 and V2. And whenever we're defining a normal P wave, we will see in both the leads, one is in the V1 and one is in lead 1 and in the limb leads. So it should be less than 2.5 millimeter in the limb leads, less than 1.5 millimeter in height in the precordial leads, and the width should be less than 40 milliseconds. So this is to understand why the atrial activity in lead V1, V2 may be biphasic. This is the section across the transverse section across the heart. We see the right atrium is here, the left atrium is here. So if I imagine my lead V1 here, this is where V1 is going to be placed. So there are two activities that is there. So from the right atrium, there is going to be activity towards my left atrium. So the initial deflection from the SA node will initially activate the right atrium. So it's a positive wave coming towards me. So you're going to get a positive deflection in the initial part of the V1. After that, the electrical impulse goes from the right atrium to the left atrium. The left atrium, as you remember, it is placed most posteriorly. So because the electrical activity is going to go away from it, you are going to get a negative deflection. So that is why the P wave in lead V1 and V2 is usually biphasic. So that is about the P wave. So P wave, the normal duration and the normal dimension should be known. So next we'll come to the QRS complex. So once the atrium is activated and the entire blood comes and enters the ventricle and the ventricle has to be activated. The ventricular activation takes place in three parts, which is the QRS complex. The QRS complex has three parts, which is the Q wave. So the initial Q wave is because of the activation from the left to right. Why this activation happens is because of the very important septal fascicle of the left bundle branch. The septal fascicle here is going to be activated first. So it activates the ventricle in this manner from left to right. So can someone tell me, so if I have leads here, which are the lateral leads, one AVL, V5 and V6, it is going to denote a positive deflection or a negative deflection. The lateral leads will show a negative deflection, correct. Very good. So it is normal to find a normal Q wave in the lateral leads 1 AVL, V5 and V6. So once you have the septal activation, then the entire ventricle is going to be activated via the Purkinje fibers. So this ventricular activation takes place in two steps. One is the major portion of the ventricle here. And because the left ventricle is more having a better muscle mass than the right ventricle, the predominant direction of movement will be towards the left. So that means the R wave, the positive deflection, it is going to show a positive deflection here. So can you say that this positive R wave is going to be maximum towards which lead? This positive R will be maximum towards which lead? There are a few leads here. So which leads will show maximum R waves? V6, correct? Lead 2, correct? Correct. Excellent. Lead 2, 3, yes, good. Yeah. So it should be lead, in the precordial leads, we have V4 to V6 that are predominantly exactly looking at this part. So V4 to V6 will have maximum deflection there. AVR will show completely negative here. And in the precordial and the limb leads, it is going to be lead 2, lead 1 and lead 3. The maximum will be in lead 2. Once the major portion of the ventricle is activated, we will go to the postero-basal wall of the ventricle, which is the basal portion of the heart. This basal portion of the heart is going to show something similar like left side to the right side activation. So that means, can you tell in which lead it is going to be positive and which lead it is going to be negative? So let's take first the limb leads. So you tell me in AVR what is going to happen, and in the limb leads what is going to happen. We have here the 2, 3 AVF, here we have AVR. Yes, correct. So we have AVR positive, correct? What about 2, 3 and AVF? Very good, correct. So we have AVR which is positive, correct? What about the inferior leads? 2, 3 AVF, correct. 2 is negative, correct. 2 is negative. Predominantly 2 is in this direction, so 2 will be negative, correct. So this is the next deflection that you get, which is the negative wave. So here we got an initial negative wave, followed by a positive wave, and then followed by a negative wave. So this is what is called as a QRS complex. And very important to remember is the direction of depolarization. It is always from the endocardium of the heart to the epicardium of the heart. Why is this very important? We will understand when it comes to the T wave. So this is a summary of what is going to happen. So initial vector here is towards the left, the septal activation, then the major vector here because of the left ventricular mass, and then we have the basal portion of the heart that is depolarized by the S wave. So once we know this, we have to understand the nomenclature, how we name the QRS complexes. So the initial deflection is called as the Q wave. The first deflection, if it is negative, it's called as the Q wave. Whereas if the first deflection is positive, it is called as the R wave. The first negative deflection after the R wave is called as the S wave. And if there is another deflection after this R wave, which is positive, it's called as the R prime or R dash. And if there is a negative deflection after this first negative deflection, it is called as the S prime or S dash. And many times you will see that RS R dash, and when you see some letters will be written in some letters will be written in small letters and some will be written in capital letters. That is because of the relative amplitude. So we'll understand this. So you can put this in chat. So how do you name this complex? How do you name this? Yeah. So yes, correct. So let's wait for some more answers. Correct. Someone says QR. Most of them are saying it's a QR. Correct. So it is a small Q here we have, because the Q wave is small and we have a tall R wave. So this is a QR complex. What about the second one? Can someone tell the second one? Second one, QS, Q, okay, yeah. So because there is no R wave, so this is, yeah, technically it should be called as a Q wave, but the nomenclature that we give is a QS because there is no R wave at all, and it's very deep. So it's a very deep, purely negative deflection. It's called as a QS wave, correct. It's called as a QS wave. What about 3? Can someone tell what is it called? Correct. Q, R, and S. Very good. So we have a big Q, a big R, and a small s. Correct. This is called as a QRS. Very good. What about the fourth one? This is 4. Correct. It's called as Q, R, and S. A small q, a capital R, and a small s. What about 5? What about 5? Correct. So a capital Q and a small r. Very good. What about 6? Excellent, excellent, excellent. RS, very good. What about 7? 7? Yes, correct, correct, correct. So we have a small r and a big S, correct. What about the 8th one? I'll come to that, I'll come to this. Yes, correct. RS R prime. Someone has written very well. Home ideas, very good. Or RS R dash, very good. George, correct. Everyone is correct, yes. Dr. Soparnika, yes, correct. We have a small r, a deep S, and a R prime or R dash, correct. What is say 9th one? Someone has already written R dash, correct. This is called as a R dash. No, that's what. Q won't come. If the negative deflection is the first to begin with, you call it as a Q. If you already have a R wave, you have to call it as a S wave after that. Any negative deflection after the R wave is called as a S wave. So this can be called as a RS R dash. RS R dash. This is small RS R dash. Okay. And this is the last one. 10th one. Correct. RS and R dash or R dash. Correct. So this is the nomenclature. Very important because you will see in many of the bundle branch blocks, this is how it will be described. It will say RSR pattern in V1, wide S wave in lead 1. So you should know how we name these QRS complexes. And someone had asked me about this lead second one. So it is called as QS because it is unlikely that you get only a very huge Q without a negative activation of the basal portion. So that is why it is called as QS. It is just a nomenclature. Okay. So this is the QS complex. So whenever you get this, you think of a left bundle branch block. We'll have bundle branch blocks also in the coming classes. So once we know how the QRS is named and what each represents, so we'll see what is the importance of Q wave. So when do we call it as a pathological Q wave? Very important to define what is a pathological Q wave. So it is called a pathological Q wave when you remember as one box. You just remember as one small box. We'll see what is that. So if the time duration is more than 0.04 seconds, it is called as a prolonged Q wave. Or if this Q wave height is more than 25% of the next R wave, then it is pathological. Otherwise, it is physiological. So this is how we define pathological Q waves. So can you tell in which leads you can get physiological Q waves? We discussed this, just an application of it. In which leads you can get Q wave normally? Lead 2, correct? Okay. So what are the leads that are there here? Correct. V5, V6, correct. All the lateral leads. One AVL V5, V6, you can get Q waves because it is lateral wall that is being seen here. So Q wave is this direction, so you can get. So whenever you see that, you should not get scared. Okay, maybe there is an MI there. No? So if it is pathological at that point, then it is significant. This is a Q wave. So we've seen the QRS complex. Then we'll come to what is a T wave. So T wave represents ventricular repolarization. So the entire ventricle is activated now. So it has to relax now. So that is what is represented by the T wave. The T wave represents ventricular repolarization. A repolarization means it is having a negative deflection. So we'll see why it is going to be positive. So even though the T wave is a negative wave or negative repolarization wave, it is still positive. That is because of the direction. We understand that with an image subsequently. You see a normal T wave, it has a smooth upstroke and downstroke. You'll see very soon. Okay. Very important. Remember these 2 points whenever you have T wave. The net direction of the T wave will be in the direction of the net QRS. So if the QRS is predominantly negative, that means, see this. So the QRS is positive. So the net QRS is the sum of Q, R and S. Q is a negative, so you have to subtract it. R is positive, you add it. And S is negative, again you subtract it. So that is called as the net QRS. So the net QRS and the T wave usually go hand in hand. Okay. So if it does not go hand in hand, then it means there is something else. There is some abnormality. So we'll see how do you determine the end of the T wave for QT interval calculation. And very commonly asked question is, what is a tall T wave? So the normal T wave is less than 5 millimeter in the limb leads and less than 10 millimeter in the precaudal leads. So anything more than 5 millimeter in the limb leads and more than 10 millimeter in the precaudal leads is called as a tall T wave. So a summary of the same. So 1/3 to 2/3 of the size of the R wave, height less than 10 millimeter. And very important here, the T wave inversions. It can be physiologically seen in lead 3, AVR, V1 and V2. Take home message is, whenever you see a small QRS with a very large T wave or a very huge QRS with a very small T wave, you think it is abnormal. So we'll see here. You see here, this is the direction. So this QRS is positive, whereas this T wave is completely negative. That is the first observation. The second observation is, if you look at the R wave here and look at the T wave here. The T wave is almost bigger than the R in lead 3 and almost equal to the QRS in lead AVF. So this is clearly abnormal. Whenever you see this, what do you think of? Can anyone tell what will you think of whenever you have something like this? Any guesses? What could be the diagnosis? Probable diagnosis? Correct. Yeah, you should think of, correct, very good. You should think of ischemia, correct. Whenever you have something like this, which is a mismatch, you think of a ischemia. Okay. Any other observations in this ECG? Apart from the ischemia, bradycardia, very good, bradycardia. We'll come to how do you determine heart rate soon. Anything else? How are the QRS complexes? No P wave. P wave is there here. So we'll come to it. See, you are seeing a very good P wave here in lead 2. This is a P wave. This is also a P wave. So are you saying that all the QRS looks very small, very small? You see all the 12 leads look small. So it is it is narrow. And all these complexes look very small. Yeah, in which lead you should see? You see here, there is a small P wave here. I agree, lead 1 is not very clearly seen. So we'll see how do we, what all you should look at when you are seeing an ECG and what are the interpretation we'll do. At the end, we'll come to the entire summary of everything. Okay. So yeah, so this is called as low voltage complexes. So whenever you're having low voltage complexes, so we should think of hypothyroidism or COPD. There are other differential diagnoses. We'll come to all of that. Okay. So low voltage complexes here. So there's a caveat in this. So I'll come to this after I finish some parts. Okay. So you see here, this is what I was trying to highlight. The T wave and the R wave are exactly almost equal, or the T wave is more than the R. So this is clearly abnormal. Okay. And you see the T wave. So the depolarization I said is traveling from the endocardium to the epicardium. So it's a positive charge going towards an electron. Whereas repolarization is going to happen from the epicardium to the endocardium. So if it's happening from the epicardium to the endocardium, a negative wave is going away from the electrode. That is why the T wave is positive. Okay. And depolarization is almost very simultaneous, very quick and very simultaneous, whereas repolarization is a very slower process. And how do you define the end of T wave? This is also very important. You draw a tangent at the peak of the T wave, you draw a tangent, and where it intersects the baseline, so that would be the end of T wave. So to calculate a QT interval, this is what you should do. The end of the T wave. So that is the QT interval. So we'll come to all of the intervals. So how do you define a tall T wave? More than 10 millimeter in the precordial leads and more than 5 millimeter in the limb leads. So the three differentials for a tall T wave: one is hyperkalemia, one is hyperacute ischemia, and one is a normal variant. Normal variant we'll see next. So hyperkalemia. So the morphology of the T wave, two things you remember. Whenever there is a tall T wave, you look at the morphology. So it is symmetric and it is narrow. At the peak, it is narrow and pointed. So it is like a tent that is placed. So it is called as tall tented T waves. That is what you see in hyperkalemia. So it is tall, it is symmetric, and it is sharp. Whereas if you see hyperacute ischemia, it is symmetric, but the base is very broad. Here the base is narrow, and the tip is not very sharp. Okay. So these are the points that distinguish between ischemia and hyperkalemia. There can be some normal variants. The morphology of the T wave gives the clue. You see here, it is not exactly up and down like this. So there is a symmetry. So it initially it curves like this and then comes down sharp. So initially it goes like this and comes down sharp. So initially it goes like this and then sharp down. So initially it goes like this and comes down sharp. So this is a normal variant. You can see, if you take any ECG, you will see very commonly you see this. It's called as a normal variant. Okay. So we understood the Q wave, we have seen pathological Q wave, we have seen with respect to T wave. So we'll come to something called as the R wave progression. So remember this, that as you go from lead V1 to V6, the R wave goes on increasing because the electrical activity is going towards it more and more. V4 to V6 have maximum electrical activity towards it. So the R wave will be maximum there. And if the R wave is maximum there, the corresponding opposite lead will show negative deflection, which is S wave. So V1 will just the S wave, and V4 to V6 is the R wave. So there is something called the transition point. So transition point always is between V3 and V4. So that is called as a normal R wave progression. You expect this to happen at V3 and V4. If it is delayed, it is called as delayed R wave progression or poor R wave progression. So the technical definition for it is you take the V3 R wave. The R wave height in V3 is less than 3 millimeter. You call it as a poor R wave progression. So these are the causes. So most common would be an anteroseptal MI. You can get an LVH, severe LVH, left bundle branch block, abnormal lead placement, and normal variant is a diagnosis of exclusion. After you rule out everything is when you call it as a normal variant. Okay. So this is poor R wave progression. You see, you take lead V3, there is hardly any R wave. V4, no R wave, nothing is there. So this is poor R wave progression. Same thing here. So hardly any R wave. So there is no R wave at all. See here you get very small R wave. But V3, V4, there is poor R wave progression. So you expect it somewhere in V3, V4, which is not there. So there is poor R wave progression. And this patient had a old anterior wall MI. So this patient had some EF of 40%. Okay. So this is poor R wave progression. So you have seen the common waves. You have seen the P wave, the QRS, the T wave, and very important is the U wave. Commonly you will see, and rigorous evaluation happens for the U wave. So you should know when to evaluate, when not to evaluate. So U wave, there are multiple theories of why it is formed. One is something called as the papillary muscle repolarization. One is something called as the activation of the mid-myocardial cells. So there is something called as a myocardium. In the myocardium, in the middle portion of the myocardium, there are M cells. That activation is called U wave. So they're all hypotheses. We really don't know what causes U wave as of now. But remember that it is a wave that is seen immediately after the T wave, and it is a positive wave. Immediate deflection, positive after the T wave, and very important is the deflection is less than 25% of the T wave. Very important. It is less than 25% of the T wave, and usually it is less than 1 to 2 millimeter. So this is the normal height of the U wave. And important is these three things. So the U wave is inversely proportional to the heart rate. So as the heart rate comes down, you can see in many ECGs of sinus bradycardia, you'll see a small U wave. That is normal. So as the heart rate comes down, the U wave becomes more prominent. As the heart rate increases, the U wave disappears. And if you're getting a prominent U wave, that means it is more than 1.5 or 2 millimeter, or it is more than 25% of the T wave, then you should think of hypokalemia. Most common is hypokalemia. That is pathological. And whenever you have inverted U waves, you think of coronary artery disease. You see here, so the heart rate here is somewhere around 60, around less than 60 beats per minute. So this is bradycardia. So in bradycardia, you see here, you are seeing some beautiful U waves. Okay. So in bradycardia, you can see these U waves. They are normal. But you see here, this is a case of hypokalemia. So whenever there is a potassium that is low, so you get very high amount of U waves. So you see this is a T wave here and U wave merging here. So this is called a biphasic T wave where initial portion is negative and then the following portion is upright. Okay. So this is something called as Nick-Elechem T waves. So a very peculiar name that has been given after some scientist who discovered this Nick-Elechem T waves, wherein initial portion is negative followed by an upright portion. So that is suggestive of a hypokalemia. Whenever you see something like this, think of hypokalemia. And inverted U waves. So this is very important. Whenever you have inverted U waves, think of a coronary artery disease, ongoing coronary artery disease. Okay. So you have the QRS complex here, and you see here the T wave, the U wave, which is completely inverted. So whenever you have something like this, you think of an ongoing myocardial ischemia or a severe coronary artery disease. And after all this, a very brief note on what is a tau wave. So atrial repolarization is very, very silent on the ECG because it correlates with the QRS compound, which is ventricular depolarization. So the atrial relaxation and the ventricular depolarization is synchronous. That is why we don't get any obvious abnormality in the ECG. So once we have understood what are all the waves, so we will come to what is the ECG paper. We'll see what are the intervals segments after this. So once we understand that, we will go to the axis calculation and the interpretation of a normal ECG. Okay. So summarizing the entire QRS, the entire genesis of the any wave. So here we'll just very briefly. So P wave is because of atrial depolarization. Then here you are seeing very nice small Q waves, small Q waves. So this is the lateral leads. So you're seeing a Q wave which is physiological. Then we have the activation of the major portion of the ventricle forming the R wave. Then we have the small S wave that is because of the basal portion of the heart getting activated. Then we have the T wave that is because of ventricular repolarization, and we have the U wave because of papillary muscle repolarization. So this is what we have seen. We have seen what is pathological Q wave. We have seen about R wave progression. So you look at the R wave progression here. You see there is a small R, then the R wave increases, then a very prominent R. So it becomes biphasic by lead 3. And then the R wave progressively increases and the S wave progressively disappears. So this is R wave progression and poor R wave progression, and this is the summary of the electrical events in the heart. We will see about the ECG paper now, because no matter what our waves we see, it is finally interpreted on the paper. So understanding the paper is of very, very most importance, because the paper has two axes. One is the x-axis, which represents time, and the y-axis, which represents the amplitude. The normal paper has large boxes and small boxes. This is called as a large box, and this is called as a small box. One large box is 5 mm by 5 mm, very clearly given here, 5 mm by 5 mm, and one small box is 1 mm by 1 mm. Why? Because each of this has 1, 2, 3, 4, and 5. 1, 2, 3, 4, and 5. So there are 25 boxes. So each of this whole thing is 5 mm. So 5 by 5 is 1 mm. So each box is 1 by 1 mm. So we'll see what is the time here. So the speed of the ECG is very important. It runs as 25 millimeter per second. So it moves 25 millimeter in 1 second. So that means 1 millimeter will be equal to 1 by 25 seconds, which is 0.04. That is what we get, 40 milliseconds or 0.04 seconds. So that is why I said here, when we saw the Q wave, the duration, if it is more than one small box, this is one small box. If it is more than that, then it is again pathological. So this is the speed at which it moves. So 40 millisecond is one to remember. So 1 is 0.04. So if you multiply by 5, it is 200 milliseconds or 0.2 seconds. So it is a graphical representation of electrical activity with respect to time, where we have time in the x-axis, amplitude in the y-axis. One large box has 25, one small box has 1 millimeter, the speed is 25 millimeter per second. So a very, very important concept once we start beginning to interpret the ECG. It's called as standardization. So standardization, so it is, we see any ECG here, you see here, it will be given here, the amplitude. So the amplitude should be 10 millimeter and it should be calibrated to 1 millivolt. So 10 millimeter is equal to 1 millivolt. That is the normal standardization. And the speed of the ECG paper must be 25 millimeter per second. These are the first things to observe whenever we are seeing any ECG, the standardization.
Hello.
So half standardization is exact half of this. So which means it is only 5 millimeter here. And so something called as double standardization. So that is 20 millimeters. So we have here 20 millimeter. So what is the implication of it? We will see now. So we saw the previous ECG. So can someone tell me what is abnormal here? What is this? Half, full, double? What is abnormal in this ECG? Correct, correct, correct. So it is half standardized. Very good. So because it is half standardized, how is the QRS complex looking? It looks very small. It has to be exactly double of this, but still it is appearing half of it because of the standardization. So this is the effect of standardization. So if we just label this as a case of low voltage complexes and start evaluating for it, it is grossly wrong. So this is the effect what standardization can have, and very, very common. You inevitably you see, especially in these COVID times, most of the ECGs are very badly standardized. This was exactly a patient from the wards. This patient had inferior wall MI, but this you see the standardization abysmal at 5 millimeters. So that is important. What about this? Grossly you see such huge QRS complexes, unexplained. You think in a young male, you see such QRS, you get scared. 20-year-old, 20-year-old, 25-year-old coming with such huge, you think whether he has an athlete's heart, you think it is a cardiomyopathy, you're really lost for words. But you look at the standardization again here. Standardization is almost 4 times, 40 millimeter per millivolt. So it is 4 times. So this QRS should be exactly 1/4 of what is being shown. So that is the effect what standardization can have. So whenever you see the ECG, the first thing you look at is this, whether it is well standardized or not. If it is not standardized, your entire interpretation will go wrong. So once we know what is standardization, so we will start looking at the intervals and the segments. So what is an interval? What is a segment? A segment is an isoelectric line on the ECG, whereas interval has an isoelectric segment with a wave. So commonly and relevantly, what do we have? We have the PR interval, we have the QT interval, and the ST segment. These are the 3 things we look at. So what is the QT interval and what is its importance? So this is the QT from the onset of the Q wave till the end of the T wave. So that is the QT interval. So if you see any ECG, it would have been given here, QT. But you see the heart rate here, so fast, very fast heart rate, almost 100, 104, 105 beats per minute. So the QT interval will change with the heart rate as well. So you see the previous ECG here, very slow, whereas you see that very fast. So that is the inherent problem with this QT. So they said we will give a correction based on the heart rate, which is called as a corrected QT. So the formulas, there are many formulas for correcting the QT interval. Most commonly used as a Bazzett's correction. So we'll see how you apply that very soon. And we saw that the QT interval correlates with the action potential duration. We saw in the first initial one. And normal value, you just remember all of these values of all of the waves and the intervals with respect to the small squares, the number of squares. That is easier than remembering as the time duration. You can convert it to time when someone asks. So the normal correction is Bazzett's used, others are Friedreichia, Hodges and Framingham. Each of it has its own advantage and disadvantage. So we'll see whenever you are seeing long QT syndrome in the further arrhythmia section, maybe we can see that. So the normal value in male and female is very different. Male it is 440, female it is 450. And what are the leads best to measure QT interval? It is lead 2 and lead V5. That is importance. And there have been many studies that say that Framingham or Friedreichia have a very better ability to correct the QT than the other leads. So what is Bazzett's correction? Bazzett's is the onset of the Q wave till the end of the T wave to the end of the T wave here. So here it is, you calculate that in seconds. All of these are calculated in seconds. So the QT interval in seconds, so this is the QT interval in seconds, we get it as 0.52. And the RR interval here is, this is the RR interval from one R to the other R. So here it is 24.5, 5, 10, 15, 20, 24, 24 and a half. So it comes to 0.98. You take the root of that. So you get 53, 0.53 or 530 seconds, 530 milliseconds, which is clearly abnormal. So that is when you have all sophisticated methods. So how to do an eyeballing method? So a normal, you compare the QT to the RR interval. So the normal QT, the T wave should end before half of the RR interval. So if these are 4, so somewhere the QT should be before this line. So here the T wave is ending just before it. But if you see here in the long QT, so this is exact midway and this T wave is overshooting this midline. So this is called as the eyeballing method. So if it is crossing more than halfway, then it is called as a long QT. Okay. So this is a very short way to use, but you use this only when the heart rate is somewhere around 60 to 70. If you use that beyond very fast heart rates, it may not be very useful. And why are we so fussy about what is this QT? Why should it be long? Why should it be short? Especially in these times of COVID, we have drugs like azithromycin that prolong the QT along with HCQ again. So double combination. So if the QT is prolonged, this is what results. It's called as a torsade de point, which is a twisting of a spike. It's a ventricular arrhythmia. Because the action potential is prolonged predominantly like this. So the relative refractory, there's something called as a relative refractory period in any action potential. And during that time, there is calcium influx that is going to happen. And this calcium influx is what is going to trigger this arrhythmia. That is why we give a calcium scavenger like magnesium. Treatment for torsade is magnesium. That is because of this reason. So we want to prevent this from happening. That is why we monitor QT very carefully. So this is a summary of the entire activations, the waves and the intervals. The PR interval is 3 to 5 small squares. You remember as 3 to 5. So 3 is 0.12 and 5 is 0.20. So this is maximum. So if it is more than that, there is a prolongation of the PR interval suggestive of a AV block. So we'll discuss all of these AV blocks in the subsequent sessions. QT interval, I said 8 to 10. And ST segment, there is based on the morphology. So ST segment will be detailedly discussed when we are discussing coronary artery disease. So this is about the normal ECG. So this is the morphology of the ST depression. So when we saw that we have the P wave, then we formed the PR interval, then we had the QRS complex, then we had the ST segment, we have the T wave and the U wave. This ST segment can either be depressed or elevated. So this is the ST segment. You see, this is the ST segment, S and the T. to the ST segment. So whether it is depressed, elevated, so all that depends upon the morphology. So there is something called as an upsloping ST depression, downsloping ST depression in the horizontal. So what this exactly means is the morphology, how it looks. So morphologically, it looks as if it's going upwards. This looks as if it's going downward, and this looks it is horizontal. What is the implication of this is an upsloping ST segment is normal. Downsloping is abnormal. Horizontal is again abnormal. Downsloping ST may be seen physiologically whenever you have a bundle branch block or severe LVH or strain pattern, you can have this downsloping. But horizontal ST is always abnormal, suggestive of a ischemia. And there is something called as a J point, which is the point of meeting of the S wave and the onset of the T wave. So when the T wave takes off, so this point is called as a J point. So you see here, can someone tell what is the morphology of the ST segment here? Upsloping, downsloping, horizontal. Can someone tell what is the morphology of the ST segment? Downsloping, correct, correct. Sloping, downsloping, good, good. We have mixed answers, correct. Upsloping, correct. So predominantly we have both actually. It depends on what lead you're seeing. See here you have downsloping ST segments. Here you're having upsloping. So this is upslope, this is again an upslope. This is again an upslope. This is a downslope. This is also an upslope. So you see there is so much uncertainty here. So that is why they came up with something called as ST80. So that see, someone may say there is ischemia, some may say there is no ischemia. So there is a lot of discrepancy there. And some may say J point is elevated, some will say J point is depressed, lot of controversies there. So they say they came up with something called as ST80. So you measure the ST segment at 80 milliseconds after the QRS. So this is 80 milliseconds. So it is two small squares. And in that, you compare it to the baseline. So the baseline you're supposed to take is the TP segment. So this would be the segment here. And at 80 milliseconds from here, if it is persistently high for more than 1.5 millimeters from the baseline, if it is depressed or elevated more than 1.5, it is suggestive of a myocardial ischemia. So that is the importance of it, because there are many normal variants where you can have some amount of depression or elevation. So that is why this is knowing this ST80 is important. And very more importance we gain whenever you are interpreting treadmill ECGs. So that is where this ST60 and ST80 come into picture. Okay. So we have seen the waves, the segments, the depressions. Next we will go into heart rate calculation. So whenever we see the heart rate, so to determine the heart rate, we look at two things, whether the rhythm is regular or the rhythm is irregular. So how do we tell the rhythm is regular or irregular? So we say it is regular versus irregular based on the RR interval. RR interval represents the ventricular activity. PP interval represents the atrial activity. So you see this R wave and this R wave, almost equal distance between each other. So this is a regular rhythm. So if it is regular rhythm, you can use two formulas, either 1500 divided by the number of small squares or 300 divided by the number of large boxes. A short method would be to use this. We'll see what is it. So here, can someone tell what would be the heart rate? You can use the large box method. It's easier here. What is the heart rate here? Yeah, somewhere little less than 300, no? Is it exactly falling on this wave? No. It's a little less than 300. Correct. Correct, correct. Yeah, around 200. Correct. So in between 170 to 200. So that is the heart rate. So how do we exactly measure the heart rate? So here we took 300, we divided by the number of RR intervals, which is big box. So here it is difficult. So you can use 1500 divided by the small boxes. But what is the importance of knowing this is very simple. Whether you are having a tachycardia or a bradycardia. That is what the clinical implication boils down to. So if it is less than 60 or more than 100, you say it is 124, you say it is 128. Is it going to make any difference? No. You say 120 and 170, that will make definitely some difference. So a very rigid value is not really required. So approximation to the nearest point is what we require. So that is why we use something called as an approximation method. So that is where we use this rule. So 300, 150, 100. So you take, so to use that, so you take the RR interval on falling on this line and you start counting the number of boxes between the next RR interval. So here it is 300, the next is 150, this would be 300, so this would be 300, the next would be 150 here. If the RR interval were to be here, it would have been 150. So, but it is less than 300, more than 150. So somewhere it should be around 200 to 250. So that is the heart rate here. So here you see, can someone tell here, what is the heart rate? So you take this is one, the second is here. So you have one box, 2, 3, 4, 5, 6. 300 divided by 6, which is 50. Okay. So you will have to, so you, as you keep seeing many ECGs, you will try to generalize. So that is what I said was 300, 150, 100, 75, 60, 50, and 40. And 43. So if this was supposed to be my RR interval, so let's say this was my first RR interval. So this started here. So this was the first R wave here, and the second R wave was supposed to be here. Then it would be 300. If the R wave was here, it would be 150. If the R wave was to be here, it would be 100. Then 75. If it was here, it would be 60, 50, 43. Correct. Correct. 50. Perfect. So here you see, I just go marching on like this. You remember these values. You just have to remember these values so that very quickly you are able to assess what is the rough heart rate. So you go on marching here. So it is here, if it were to be here, 300. So 300, 150, 100, 75, 60, and 50. So a little less than 50. So definitely it is bradycardia. So that is what is my requirement. So you just need it as brady or tachy. So it is 50, which is bradycardia. Okay. This you understood that 300, 150, 100, that rule is clear. Yeah. Okay. Any doubts with that? I'll repeat it. Yeah, exactly. Because I've had this previously. So this is the R wave. So I start here and my next R wave is here. So in between that, traditionally I'll count the number of R waves, number of large boxes. So if this is the rule, you have to mug up 300. So in case this R wave was to be here, you see the number of squares that you have to traverse. For each square, it is, you remember that value. So here it is. So this here would be 300. Here again, the next is the number is 150. Then the next number is 100. So this is the number you just by heart. This is the order that you just by heart, so that you use the same. See the number of boxes here. So it is 300 now, then 150, 100 now. So it is 100. But here you go on next because the R wave is here. So 300, 150, 100, 75, 60, and 50. So you reach here. So the point is 50. So 50. So the heart rate should be somewhere around 50. Now it's clear? Yeah. Okay. Good, good. So can someone tell for this, can you calculate the heart rate? Hundred. How? 100 to 150. Yeah. See, very important. What is the golden rule? To use this formula or any of this, the rhythm should be regular. If it is irregular, you can't use any of these methods. Correct. So the rhythm should be regular. So this is an irregular rhythm. So first thing is to look at RR interval first. You should see the entire strip here. You see here, this part is more, this part is very less, this part is more, again this part is less. So in this scenario, what is the measure to use? So we use something called as a 6-second rule. What is the 6-second rule? So you count the number of QRS complexes for 6 seconds. 6 seconds means how many large boxes you will get. Can someone tell? How many large boxes? 6 seconds means? One large box is 0.2 seconds. So 30 large boxes, correct. So you will count 30 large boxes. Very good. So you count the number of QRS in 30 large boxes. Either you can do this or you can use even the 3-second rule. 3 seconds is you count for 3 seconds. So how many large boxes you will get? 15. Good. So you get 15. So you count for the number of 15 large boxes you take, and you count the number of QRS complexes. So you start here. So how many boxes we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So this is my cutoff. So many I have? 1, 2, 3, 4, 5, 6. So I have 6 large boxes, and I have counted for how many seconds? I have counted for 3 seconds. So if I have to get for 1 minute, what is the factor I should multiply this by? Correct, 20. Very good. Very good, very good. Excellent. So I should multiply this by 20. So this is, I multiply this also by 20. So what is the heart rate I get? 120. Clear? You understood this? Okay, good. So this is clear. Fine. So that is the first point of difference. Okay. So we've seen how to calculate the heart rate. So can someone calculate for this? Very quickly we can calculate. No, 300. So this would be 300. This would be 150. So in between. So in between 150 to 200. So somewhere it will be around 200. Correct. Okay. So we have seen the major parts. So we have seen the major basics. So what is left is two things. One is axis and one is technical changes. Okay, so what exactly do we mean by axis? Axis is the representation of the net direction of electrical activity in the entire ECG. So we commonly assess the QRS axis, which is the measure of ventricular activity. And the normal axis ranges from -30 to plus 90. What do I know? Why should we know what is the axis? Lot of implications. It will help us get a differential diagnosis in the ECG for an ongoing clinical process. So let's understand this. So can you tell what is this lead here? This would be lead 1. Okay. This is going to be lead AVF. Correct. And this is going to be lead AVL. This is going to be lead AVR. Okay. We have two other leads. This would be lead 2. And this is going to be lead 3. Okay. I'm sure we all know this. Very important is the concept of a vector. We have understood it. We'll just recapitulate it. So a vector is anything that has a direction and an amplitude. So if a wave is going towards, this is the direction. So this entire portion of the activity is going to be positive. Let's say it's carrying a positive charge. this whole thing is going to be positive. And this portion which is going away from it, this whole thing is going to be negative. This entire portion is going to be negative. So if you have understood that, so we see that lead 1 here is going to be positive in this direction. That means this is exactly opposite. So we remember that we have resolved vectors in physics. So this was 0 and this was, let's say, a charge. So if we change the direction, we change the charge. This was a resolution of vectors. This was the resolution of vectors that we had. So can someone tell me what would this lead be? So this point, what can we call this? If this was lead 1 in this direction, what would this be called? If it is in this direction, exact opposite. You call it as correct, very good. So negative 1, very good. So it's called as negative of this wave because we add a negative charge to it. So if this is AVF, so this is the direction of AVF. So this would be negative AVF, correct. Correct, very good. Everyone was understanding that. Correct. So this is negative AVF. And if this is the direction of lead 3, so this would be, so lead 3 exactly is not to AVL. So it goes a little towards this side. Okay. So this would be AVL. So exact opposite would be something here. So this would be lead 3. So lead AVL will be in this, negative of AVL will be here, negative of AVR will be here. Okay. So what exactly I mean to tell is entire activity is just a continuum. So even if we don't have specific leads, these are all filled by lead negative AVF. See, we don't have this lead here, but it is negative of AVF. So that way it is entirely covered. Okay. So now what is important for us is, we'll erase this. So let's understand what we mean by an axis now. Okay, so what is the direction in which the heart's activity is going to go? That is what is called as the axis of the heart. So the net direction, we are looking only at the QRS because that is what commonly we see. Each wave has its own axis, like P wave has its own axis, the T wave has its own axis, but we look predominantly for now at the QRS. So we saw that the QRS net activity is going to be in this direction. Okay, so that is because all of the activity is towards the left side. So to understand how to plot an axis, to say whether it is left, right, northwest, north, right, there are many ways. So commonly I will use the quadrant method. So we can divide the entire thing into 4 quadrants, 1, 2, 3, and 4. This is just, I will label it according to my wish. Okay, you can label it any way you want. Okay. So this is the axis now. So how to calculate the axis now? So you take any 2 perpendicular leads. So you take lead 1 and lead AVF. So they are perpendicular. Why? Because lead 1 is 0 degree. This is 90 degree. Can someone tell what is this? This is 60, 120 degrees. So anything clockwise will be positive. Anything anti-clockwise will be negative from the origin. So this is the origin point. So this is going to be minus 30. So if that is 90, this will be minus 90. This will be minus 120. Okay. So now let's take any 2 leads. Okay. So this is going to be the activity that I'm going to represent. If I take lead 1, okay, you see the morphology in lead 1. We'll use these 2 leads now. Lead 1 and lead AVF. Commonly it is used and it's easy also. So you look at lead 1 and lead AVF. So lead 1 is predominant. So you should calculate the net QRS. What do I mean by net QRS? You subtract the negative wave and you add the positive wave. So here it is 5 plus 4, 9. 9 minus 2, 7. So net is plus 7. So if it is plus 7, this is the direction in which my activity is going to. That means from the origin, this entire portion is going to represent my lead 1. The next thing is lead AVF you look at. Lead AVF is also positive. That means this is the region of my AVF because it is in this direction. So this entire portion will be by AVF. So you condense both. So you look at both, and which quadrant is going to be common for both is this fourth quadrant. This naming is very arbitrary, but what you should remember is this is where the common meeting point is. That means the activity is predominantly in that direction. So that's how you remember it. Okay. So if the activity is, let's say, in this direction, then we will get this is called as a left axis deviation. It is towards the left here, and here this is moving towards the right of the origin. So this is right axis deviation. This is something called as a extreme axis or a northwest axis. Okay. Do you want me to repeat this or you understood it? Repeat, yes, correct. I want you to repeat, correct. I know. Correct. Yes, +7, how? Yeah, I'll come. So we'll take an example now. Okay, so we'll understand this now. See. So I'll clear the entire thing now. So we can imagine where are the leads now. So lead 1 and lead AVF. These are the only two leads. Okay. So I'll give quadrant numbers. Now I'll just give polarity. So here, from here, anything here on x-axis here is lead 1. So this is going to be plus and plus. So this represents the x-axis, this represents the y-axis. So in this quadrant, lead 1 is positive, lead AVF is also positive, correct? So lead 1 is positive, lead AVF is also positive. So can someone tell me in this quadrant how it is going to be? Lead 1 is going to be, you can just put the plus minus plus whatever it is. So here AVF is going to be negative and lead 1 is going to be positive. So this will be plus and this will be minus. Good. Plus and minus, very good, correct. You're understanding this part now, plus and minus. Okay. So can someone tell me here what is it going to be here? Here it's going to be, so lead 1 is going to be negative. Yes, very good. So this will be minus and minus. Very good. Can someone tell me here what it will be? Minus and plus. Very good. Excellent. So everyone is understanding. If you know so much, you have mastered axis. So if an electrical activity is going to be here in this direction, what would be the coordinates now? Can you tell? Plus and plus. Very good. If it is now here, what would it be? If it's in this direction, negative. Very good. You have understood it. That's it. Now, see the same thing here I have told. The same thing I have tried to explain. Now you tell me what it is. So here, if it was here, I called it as a normal axis. If it came here, I called it as a right axis. Here I call it as a left axis. Here I call it as an extreme axis. This part you understood, correct? So this much I'm sure we all have understood. So let's begin with an example only. So what is the net QRS here? So here you are seeing 1, 2, and 3. 3 small squares, which is positive, and 5 plus 5, 10. So 10 is negative. So here we are getting a total of minus 7. Correct? So lead 1. So this is all really not required. So whether it is negative or positive, I'm just doing this as an exercise. Lead 1 here done. Then you look at lead AVF now. AVF, what is there now? See, there's one small Q wave which is 1 millimeter. You minus that 1, and what is the one more here? 1, 2, and 3. So minus 3. So we get a total of minus 4, and you add what is the positive wave here? So 1, 2, 2 plus 5, which is 7. So this is again positive. So the net is positive. So you draw now where it comes. So 1 is negative. 1 is negative. So If it is negative, two possibilities, either here or here. Okay, but here AVF is going to be positive. That means where is it going to come? 1, 2, 3, and 4. Correct. Yeah. So it's going to be in 3. So which is right axis. Correct. So this was right side. Correct. This was right axis deviation. This was left axis. This was extreme axis. And this was normal axis. Understood? You understood this axis now? Right axis. Yeah, you have understood. Okay, let's see what about the others. Yeah, you can take any two perpendicular leads. It's easy to take 1 and AVF, so I have taken 1 and AVF. You can take any two perpendicular leads. Okay, we have understood. So can someone tell me what is this now? So lead 1 is negative, predominantly negative, so it should be here or here. And AVF you see predominantly negative. So what do you think this is? What is the axis in this patient? Extreme axis, very good. Extreme axis, very good. So you understood. So this is extreme axis, correct. Okay. So I hope this is visible. So can someone tell me here, what is it? So here we have lead 1, which is going to be negative. So this is positive lead 1. This is going to be negative lead 1. You can go on commenting. I'll see the answers. So this is lead 1, which is going to be negative. Lead 1 is negative. This is AVF. Okay. AVF. This should be AVF. Okay. If it's not visible, I'll just write it here. This is AVF. This one is AVF. And AVF is positive. So let's see the other answers. Yeah, correct. So everyone is correct. Correct. It's right axis. So lead 1 is negative. Lead AVF is positive. So it is right axis. Okay. So if you imagine this to be like this, now you see lead 1 is like this. Lead AVF is like this. Correct. Only then you are going to get something like this. You are going to get a right axis. Yeah, there are no P and T waves in AVF. Correct. There is actually some small P wave here. This is a ventricular tachycardia. And very, very important. I'm sure it will be told next. A ventricular tachycardia, not always will you get a extreme axis. You can get right axis, you can get left axis. Okay. So here you see lead 1 is going to be like this, lead AVF is going to be like this. So in a right axis deviation, lead 1 is negative, lead AVF is positive. That means whenever we have a right axis deviation, both seem to reach each other. Both are coming towards each other. So it's called as right. You can remember as reaches. So both reach each other. So you can remember as right reaches. Okay. There are other examples also. So if it is left axis, so 1 will be positive, AVF will be negative. So if it is a left axis, you can see here. So if it's like this, so 1 is going to be positive and AVF is going to be negative. So both are seeming to leave each other. So you can remember as left leaves. So very quickly you will be done. Okay. So this is, can you explain the extreme axis? Yeah, sure. So whenever we have a lead 1 which is negative and AVF is also negative, it's called as an extreme axis. So can someone tell me from where should be the direction of activation? So if let's say the origin is somewhere here, from the LV apex there is an activation and it is going towards the AVR. Only then you will get AVR positive. So if it is an extreme axis, you will get AVR positivity. This lead will be positive. You're able to understand this, no? Why AVR will be positive? Because it is going towards here. So this, if the axis is in here, it's called as extreme axis or no man's land. Okay. So if we understood left axis, we will come to a very important concept called as physiological left axis. I said 0 to 90 is not normal axis, it is minus 30. Okay. So we will use the help of lead 2 with that. It's called as quadrant plus lead 2 method. So again, we'll use the concept that we have learned, which is if the lead is perpendicular to the flow of current, it is going to be biphasic. Correct. So after you look at this, so let's say there is a left axis. We'll see a left axis. Okay. I'll explain this. Then at the end we have examples. We will work upon that. So if there is going to be a left axis deviation, so it can be either here or it can be either here. So if it is going to be here, so minus 30. If it is minus 30, which is AVL, along AVL, so exact perpendicular to this would be plus 90 or minus 90 you add. So if you add 90 to it, you get 60, which is lead 2. So that means you look at lead 2 next. So if this is the direction of activity, you look at lead 2. So if lead 2 is perpendicular, that means it has to be like this. So this is the direction of lead 2. This whole thing is lead 2. This whole thing is going to be lead 2. So if an activity is going to be like this, so then the lead 2 will be perpendicular. In case it is like this, that means it will be more negative. If it is towards this direction or more towards this direction, it will be more positive. You are getting this point? This is going to be the direction of my lead 2. I'll repeat it. Okay, this is going to be my direction of lead 2. So if this AVL here is going to be a perpendicular lead to it. So if there is going to be an electrical activity here, it is going in this direction. Okay. So exact perpendicular means lead 2 will be biphasic. So if it is going to be a little beyond like this, that means it is going more away from lead 2. That means lead 2 will be more negative. Here lead 2 will be more positive. Let's say here. So if the activity is here somewhere, then it is going to be more positive, less negative. So if it is more positive, that means it is physiological left axis. Otherwise, it is going to be pathological left axis. Now we have understood. Now is this clear? This point of using lead 2. Is it clear? Yeah, okay. We'll see examples. So the last part, okay. So quickly, we'll finish it. So can someone tell what would this be? The first one, axis, normal, left, right, or center, or extreme. First is going to be normal, correct. Okay. The second is going to be, can someone tell what is this one? Lead 1 is positive, lead AVF is negative, so it will be left axis. So you'll use lead 2 to say whether physiologic or pathologic. If lead 1 is negative and AVF is positive, it will be right axis. Very good. And if both are, it will be extreme axis. Good. So you have understood this. Good. So most important now. So once you are given an ECG now, so with this you will start interpreting the ECGs. Okay. So the first thing that you look at is the standardization. So we'll start interpreting ECG. So we'll see how you should interpret the ECG as well. So the first thing is look at the standardization. So once you look at the standardization, so you see it is 10 millimeter per millivolt and speed will be mentioned, which is 25 millimeter per second. So let's say this is normal. The second thing is you look for technical abnormalities. You look at, the first thing is look at lead AVR, because you should get a positive wave in lead, you should get a negative wave in lead AVR, correct? But the P wave is positive and the QRS is also positive. Okay, so that means it is, the activity is going towards AVR, so which is not physiologic. Okay, and there is, whenever you see this scenario, you look at lead AVR. So two possibilities are there. One is a dextrocardia, a true dextrocardia where patient has heart towards the right, so you will get dextrocardia. So you will get something like this, or whether it is a left arm, right arm swap. Very, very common in the wards. This is an actual ECG. So they would have swapped the left arm and the right arm. So if you see the Einthoven's triangle, so this is my left arm, this is my right arm. So normally this is the direction of movement and this will be lead 1. Okay. So if I swap this, so this will be my right and this will be my left arm. So this entire thing is going to get swapped as -1. Okay, so that means the entire lead 1 will become negative. Okay, and normally this is going to be my lead 2, correct? So which is between right arm and the left leg. So now this is going to be lead 2. That means lead 3 is the new lead 2. So this is going to be my actual lead 2. So the whole thing swaps now. So that is why you have to look at this very, very carefully. So once you see this, either it is dextrocardia or technical dextrocardia. You can call it as technical dextrocardia or swap. So how do we distinguish these two? So we have learned this concept called as R-wave progression here. So R-wave progression means as the R-wave goes on increasing in the precordial leads and the S-wave starts disappearing in the precordial leads. So here you see the R-wave is preserved. The R-wave progression is preserved. So what will happen in dextrocardia? What will happen in dextrocardia? What will happen to the R-wave progression? So is it going to be normal or it is be? Yeah, sure. You want me to repeat which part? R-wave progression? Yeah, dextrocardia. Okay, sure. I'll repeat dextrocardia. So what is dextrocardia? Dextrocardia is where the heart now normally is going to be placed like this. The cavity. It is going to be placed towards the left. This is the direction. In case it is towards the right side of the mediastinum, then it is called as dextrocardia. So this is my left side, this is my right side. So if it is placed in this direction, it is called as dextrocardia. So if that is the scenario, you can have AVR that is positive. Or if I swap my left arm and the right arm, again I'll have positive. So to distinguish those two, I will use R-wave progression. In technical dextrocardia, what will happen to R-wave progression? So in dextrocardia, the R-wave progression will be normal or it is going to be abnormal. So it is going to be lost. In extreme axis, R-wave is positive, AVR is positive. Perfect. In extreme axis, AVR will be positive. Correct. So in dextrocardia, what will happen to the R-wave progression? So someone says it is going to be abnormal. What about others? What do you think? If the heart is switched to the side, normally V1 to V4, V6 is going to be placed like this. So this is going to be the expected direction and this will be the R-wave progression. But then it is going to be in this direction. So dextrocardia, it will be abnormal. And in technical dextrocardia, it is just limb swap. But the precordial leads are normal. So it will be normal. So this is how you distinguish. This is clear, no? Yeah, in dextrocardia, it will regress from V1 to V6. Very good. We will get a reverse R-wave progression. Correct. So this is about dextrocardia. So this is technical dextrocardia. The first thing you should look at is that. Look at standardization. The second is technical error. Because if it is technically wrong, then there is no point in interpreting the ECG. So you should make sure that the ECG is correct before interpreting. So once we see this, these are the headings in which you should report any ECG. You look at the standardization first, then look at the rhythm. So what is normal sinus rhythm? Okay, please don't tell that it is every P wave is followed by a QRS. It is wrong. Okay, so you should tell the P wave that P wave morphology should be sinus. That means it should be positive in lead 1, lead 2, V4 to V6. Okay, this is the minimum, first thing. That is the origin. Then what is the relation between the P wave and the QRS? So if every P wave is followed by, so it should be a normal sinus P wave that is following a normal QRS. That is the second point. That means every impulse that is generated is conducted to the ventricle. So these 2 points should be there. And there is something called the P wave axis. So that is also should be around 60 degrees. So these are all the things that should be there to call a rhythm as sinus. So here we look at the P wave first. Once you look at that, and you look at whether the rhythm is regular or irregular. And then you look at the rate, look at the intervals. So mainly you look at the PR interval and the QT interval. Then calculate the axis, left, right, or extreme. Then chamber enlargements will be dealt in the next class. And when you're describing, I feel this is better you describe something called the QRST changes. If you make it a point to remember, you have to describe as QRST. So divide everything. So Q. So you look at where the Q waves are present, whether it is physiologic or pathologic. Next, you look at the R wave. Anyone wants to volunteer? You can just maybe comment here and we'll unmute you. Anyone wants to volunteer to interpret this ECG? I'll do it with you. This is going to be a revision of whatever you have learned this entire 2 hours. Any volunteer? Just maybe raise hand or comment. Yeah, Kushal. Okay, we'll first unmute Nandini. Yeah. Unmute yourself, ma. Nandini, Dr. Nandini.
So,
Yeah. So would you like to start interpreting? What all you will start with? You interpret this ECG. We will see.
I'll try, sir.
Yeah, sure.
Yes, sir.
Go ahead.
It is a normal standardization ECG.
Good. Then the next thing is
The rhythm, it is normal sinus rhythm.
good. After that,
Normal sinus rhythm, sir.
okay. Regular, irregular.
It's regular, sir.
It's regular, correct. So normal sinus rhythm, regular. So once it's regular, you can start with the heart rate. So what would be the approximate heart rate now?
Between, wait,
Just a little less than 100 and a little more than 75, correct?
more than 75. Yes, sir.
Somewhere around 90 to 90 to 100, because here it is 300 here. So you are using that tool. You remember the tool 300, 150, 100.
150, yes, sir.
It is little less than 100. Okay, so it is normal. So heart rate is normal. So
Around 90.
yeah, around 90, 95. Okay. Then what is the next thing?
Axis.
Axis. You want to tell the axis? Yeah, tell me axis.
One is negative and AVF is
AVF is
negative. Extreme axis, sir?
yeah, extreme axis. Okay, good. So extreme axis deviation.
Sir, and is it a tall T wave, sir? In AVF?
In AVF, tall T wave. Okay, you can call it tall, correct? Then someone yeah, correct. See, AVR.
Chamber enlargement.
Correct. Whenever you get, I'll just add this point. So whenever you get an extreme axis,
Yes.
AVR that is positive. Correct. So that's a reflection of what is happening. That means the entire activity is towards the right side. Okay. So after that, what you look for? Intervals. What about the intervals? Use small scale. Easy. So PR, so it's almost 5 is the maximum. So it is within 5 boxes. Then QT
Yes.
much
10.
So that is also normal or abnormal.
Normal, sir.
So you can use eyeballing. See, so 1, 2, 3, 4. So at the end of 2, your T wave is ending at the end of 2. That means it is normal. So intervals are over, axis is
Yes.
over. Then chamber enlargements we'll skip. What about QRST changes? I wanted to describe. So you should look at all the leads for that. So where all you are looking for Q wave now? You see all the leads. So always whenever you are seeing, you see in groups 2, 3, 1 AVL, V5, V6, then V1, V2, then V3, V4. If you see like that, you won't miss anything.
Yes, sir.
So what you are seeing here?
In 2, 3 and AVF, we have a small, almost negligible Q wave, sir.
Okay. What is the definition for pathological Q wave we saw? It should be if
If it is more than
of the
25% of our
you see
wave
R wave.
height.
See this Q wave, how much it is.
Yes, sir.
Okay. So here it is
Pathologicals.
here it is QS. We don't have R only here in 2 and AVF. In lead 3, we have a small R wave. Good. Then, so we are having pathological R wave, Q waves in the inferior leads. Then, in 1 and AVL, there is no Q wave. What about the in the precordial leads? Anything you are seeing?
The R wave progression is normal.
Okay.
No.
Okay. R wave progression is actually poor, no? There is no R wave only here. Very small R wave.
Yes, sir.
This is the maximum. See, the R wave is maximum. S wave is small in lead V1. If you see here, V2, V3, the R wave and S wave is almost equal. And here it is becoming more negative. So it is like reverse. Okay.
Reverse. Yes, sir.
Progression is not, there's a reverse progression. Okay. Then you should look at Q. First Q, then R, then S. So you should look at Q in all the leads. You have seen in the inferior leads. What about the anterior leads? Anything is there? You're seeing some small Q waves here. You're able to appreciate.
Normal, sir.
Usually in anterior leads, you will not get Q waves. That is also very important. Okay. So
Okay, sir.
in the anterior leads, like V3, V4, you will never get Q. Q represents a scar there. Okay. And see here. So we said V5, V6, you can get a normal Q wave. But here, is it abnormal or normal? Is it pathological or physiological in V5?
Pathological, sir.
Yeah, so the depth is almost equal to the R wave there. Okay. So it is pathological Q waves. Good. So we have pathological Q waves.
Sir, I have a doubt, sir. In V5 and V6, what is the wave, sir? Is it QS?
Yeah, you can call it as Q R and like deep Q, small r and a deep S. You can call it as QRS like this. R wave is like barely touching the baseline a little. So it is a Q, R and
It's
S.
like almost negligible, no, sir? The R wave?
R wave is almost negligible. So that's why you call it as a small r. Here you're seeing something above
Okay,
the.
sir.
Okay, so you can call it as QRS only. Okay.
Yes, sir.
Anything you have seen? So Q is there. There is a R wave progression that is a little wrong. Then there is a Q waves in the anterior leads as well. And we have an extreme axis. Okay. So
Yes,
in
sir.
seeing this bundle branch block channel, you will come to it. Okay. So whenever we have something like a right bundle branch, you can have sometimes a extreme axis with a scar. Yeah. This is a ST segment elevation. There is some amount of ST segment elevation. There is a definition for ST segment also, how much it should be elevated. That maybe we'll discuss in the coronary artery disease part. Dr. Ashwin sir will be taking that class. That time they'll discuss about what is a normal ST elevation, what is physiological, what is pathological. Okay. Definitely some amount of ST elevation is there, but it is within physiologic limits there. Okay. Yeah. Good.
And T waves are tall, sir.
T waves are precordial leads are okay. Here you can call borderline tone. Okay.
Yes, sir.
Okay. Good. Excellent.
Sir, can you once mention the 3 points for normal sinus rhythms or the criteria?
So whenever it's normal sinus, just imagine what is happening. So from the atrium, it is passing through. Correct. So it should be positive in lead 2. If it is passing in lead 2, that means it should be negative in AVR. And this is the direction, no? Downwards and leftwards. So that means lead 1 also should be positive. And in the precordial leads, it is going to go towards my left side. That means V4 to V6 also should be positive. So these are the points to call it a normal sinus. Okay.
Yes, sir.
Yeah. So this is an involved anterior wall image. So this is an old anterior wall myocardial infarction. Okay. So Q represents a scar, septal scar there. Okay. Good. So okay. Yeah. Fine. Next ECG. Any volunteers? Yeah, I'll summarize the whole thing. I'll summarize the whole thing at the end. So we have 5 ECGs. So this is going to be the discussion or summary of whatever we have tried to learn in the past. We'll consolidate it, and I'll at the end, about 5 minutes, I'll summarize the whole thing. Okay. So that time someone wanted to tell. Any volunteers for this ECG? Yeah, sure. iPad. Can you unmute yourself?
So yeah, so
Go ahead. Your name?
Vignesh Prakash,
Okay. From which college?
MSRMC, sir.
Okay. Fine. Yeah, go ahead, Vignesh.
So
This is for standardization. You can look here.
standardization is the normal, sir.
Okay, good.
Then it's so can you please tell me the orders, right?
Yeah, so first look at standardization, then technical error. So you look at the P wave. AVR you should look at. AVR is negative. So that is normal or abnormal?
Negative, sir.
Normal. Okay. Then,
Normal, sir.
good. So then you look at the rhythm. So rhythm, how is it? It's sinus, non-sinus.
Rhythm is bradycardia.
The rhythm is different, rate is different. Rhythm is sinus versus non-sinus. So it's positive P in lead to 1 and negative in AVR and positive again in V4 to V6. So it is normal sinus, correct?
Okay, sir. Yes, sir.
Okay, so what is the rate? So is it regular or irregular? That is the main thing. So you see,
So it's regular, sir.
it looks regular. So what are we going to do next? We have to calculate the heart rate.
Heart rate, okay. So heart rate is 3 big boxes plus
300.
so 300.
Yeah.
100, little bit less than 100, sir.
Yeah, good. So it is a little less than 100. Very good. Okay, very good. So heart rate is done. So rate is over, rhythm is over, rate is over. Then you should look at the intervals. So what is the intervals? How are they?
So PR interval, it is less than 1 box, sir.
I try to zoom. I don't know if I can.
In lead 2, it is less than 1 box.
You're able to see?
Yes, sir.
I'll tell you how much it is. It's around 3, okay? It's from the onset of the P here till the onset of the QRS. It is three boxes, okay?
Yes, okay, sir.
So that would be normal or abnormal?
It's normal, sir.
So it is normal, okay? So PR interval is over. What about the QT interval? QT?
QT interval is it is more than 1 big box plus around 2, 3 in this.
Yeah, so you should know
So it is
4 boxes. So at the end of 2, no, it is within the half of the RR interval, so which is normal.
normal,
Okay?
yes, sir.
So intervals are over. Then what do you look at?
Axis.
Very good. So can you tell me what is the axis here?
So in lead 1, it is positive, sir.
Okay, good.
And lead AVF is negative, sir.
Good. So what would be the axis now?
So positive.
So lead 1 is positive.
So left axis deviation. So then lead
How
2.
Yeah, so how is lead 2?
Lead 2 is positive. So
That means it is physiological or pathological?
physiologic, sir.
It is a physiological left axis deviation. Okay, good. So axis system. Then you look for Q.
Chamber. Okay. Yes, sir. QRST, sir.
So any Q wave you're seeing, any abnormal Q, any abnormal R. So look, leads like this. So 2, 3 AVF, there is no Q waves. Good. Then one maybe
Okay.
maybe a small this one, which may be physiologic. Okay.
Okay, sir.
V5V6 not very clear. Okay.
Precordial leads.
Yeah, precordial leads also, I'm not seeing any Q waves. Then you look at the R wave progression. How is the R wave progression here?
So it's, I think, it's normal.
It's normal. Good. So it's normal. Okay. R wave progression is normal. After that, T changes and the T wave. So you should describe all that. So T wave here, you are seeing some T wave inversions in 2, 3, AVF, V3, V4, V5, V6. Okay, so that means how you will describe this? This is the inferior wall, and this would be lateral, anterolateral. Okay, should be anterior plus V5, V6 will be lateral. Okay.
Yes, sir.
So you have to see based on the clinical setting. And one more thing most important is always interpret ECG in the background of the clinical setting. One ECG may have 1,000 findings, but what is the clinical setting in which it was done? That is what matters. Okay. So this patient, we don't know. I don't remember the history for this. So maybe if he has some chest pain and all, some T wave inversions here, so you have to evaluate it. So it has to be further evaluated. Okay, good. So
Thank you, sir.
this will be, it's a normal, well standardized normal sinus rhythm with a rate of about less than 100 beats per minute, with the physiological left axis deviation, with no pathological Q waves, a preserved R wave progression, with some T wave inversions in the inferior and predominantly the inferior and the lateral leads. Okay, so further evaluation will be required in view of the T wave inversions. Okay, so this would be the interpretation. Good. So we'll see next ECG. Yeah. So can someone go for this? I'll tell you P wave direction in AVF and AVL. Yeah, sure. Any volunteers for this? Yeah, more 3 ECGs, more 3 people, and we'll finish it. Maybe another 5 minutes, we'll close this. Anyone wants to try? You can go ahead. We are all learners. Even till today, we are also learning about ECGs. Okay, fine. I'll take this. Okay. So here, yeah, anyone?
Yeah, Balaji, can I try?
Yeah, sure. Go ahead.
Yeah. Here standardization, I think it's
Not given.
like there is no, it is not visible.
Here it's here. 25 and 10, so it's normal.
Yeah, it's normal. Then rate.
We'll go for rhythm is normal.
Yeah.
Positive in lead 2 and negative in AVR. Okay, then
Yes.
rate.
It's around 100, I think. But QRS complex is 100 rate.
the heart rate? Sorry. Okay. Is my voice audible?
Yeah, it's audible.
Yeah. So the heart rate is here. So 300, 150, 100. So this should be,
Around 100.
yeah, so less than, yeah, little more than 100. So 300, 150, 100. Little more than 100, correct? Then
Yeah.
from that,
Then
we look at the intervals now. So intervals, then axis. So what about the intervals? You can take any RR interval for heart rate. Yeah, if it is regular, you can take any RR interval. If it's irregular, you should take the average. Yeah. So here we are looking at the PR interval here. So anything abnormal in the PR interval? No.
it's prolonged, I think.
Very good. So PR interval here is prolonged. So PR is prolonged. Then the QT interval we look at. The QT interval looks overall okay.
When it's less than half. So it is QT is normal, I think.
QT is normal. Okay. After this, we look at rate rhythm intervals. What are the axis now? What are the axis?
Then lead 1 it is positive, and lead AVF it is negative. So it is going. Then we should look at lead 2 also. Lead 2 is also negative, so it is left axis deviation.
So it is pathological left axis deviation.
Axis deviation.
Left axis deviation. Good. So we have the axis now.
Yeah.
In chamber enlargement we leave. So we look at the QRST changes. So
QRS.
here we are having predominantly here it is like QS, hardly any R here.
Yeah.
But here, what about, so that is Q waves. What about here, R wave progression?
It's all S waves only. There's pure R wave progression.
R wave progression, good. So there is poor R wave progression, which is again abnormal. So poor R wave is abnormal here. Then ST changes, there are some ST changes. So there is, see, you can see here, there is ST depression and T wave inversion in 1N AVL. Whereas you see that here, there is a sharp shooting of the ST segment here in the inferior leads with the QS here. Then there is poor R wave here. So all of this, and very peculiar, there is one finding. If you see the limb leads, very low voltage complexes. Plus, if you see the precordial leads, the voltage is maintained. So this feature where you get a low limb lead voltage and a preserved precordial voltage is one of the criteria to diagnose heart failure. You can advanced heart failure, you can diagnose like this. So preserved voltage in the precordial leads, low voltages in the limb leads.
Limb leads.
Okay. Good. Okay. Someone wanted R wave progression. So R wave progression is as we go from V1 to V6, the R wave should gradually increase and the S wave should gradually disappear. Okay. So that means maximum at the level of V5, V6, you should get a very good R and a very small S, and very deep S wave you should get in V1, V2. Okay. So this is about this ECG. Okay. So this probably patient had ongoing cerebral ischemia with heart failure, some dilated cardiomyopathy or something. Okay. Fine. So what about this ECG? I think this is there. How do you say AVR is negative here? Yeah, AVR, you have to actually zoom in and see. Okay. Yeah. So this ECG, anyone taking? Poor limb lead and good voltage in the precordial leads. Yeah, okay. Go ahead.
Yeah, okay. Good morning, sir. The standardization is normal.
Good.
And now we see the rhythm. So it is a regular rhythm because...
Before you see the rhythm, you look at the technical abnormalities. You should look at AVR.
Okay.
So look at the rhythm, correct. Like describe, go on describing, correct.
Okay. After the rhythm, we calculate the rate. So the rate is a little less than 100.
Okay.
Because like the RR interval is a little more than three big boxes. So I'm saying it can be between 100 and 75.
Okay. We'll draw a line here. So this will be the onset of the R wave. So this will
Okay.
be 100, 150,
Okay.
100, 75, a little less than 75.
Okay.
Maybe the boxes are not that visible. That's okay. So 75, less than 75. Okay, good.
Okay. All right. And next we see the intervals.
Good.
The RR intervals appear to be constant. And the QT interval
Okay.
seems to be, it appears to be a little less than half of the RR interval as you had told.
Okay. So that is normal. Good. Then
Yeah. And the PR interval should be less than 5 boxes, small boxes.
which is less. Good.
Okay.
Then
And next, chamber enlargement we're not seeing now. And then we see the waves.
okay.
I'm not sure about the P waves, sir. The R wave,
So we'll go, you see any first Q wave. So any Q waves here, we are not seeing any Q waves. Okay. Then look at R.
okay.
You see here, R wave usually progression should be V3, V4. But here you see very
Yeah.
it started off in V1 itself.
Yes.
Okay, so that in subsequent we'll know that it is a feature of bundle branch block. An RBBB can have a all R wave. Okay, good. After
Okay.
R wave, so then
And next,
C waves. You're seeing some inversions in V1.
yes.
What about the axis? We forgot the axis in between.
For the axis, yes, sir. The axis in we see in lead 1 and AVF. It is negative in V1 in lead 1 and positive in AVF.
Okay.
So I'd say right axis deviation.
Very good. Right. Okay, so that's it. So this is a case of a right. The diagnosis here is actually a right bundle branch block. So because of a right bundle branch block,
Okay.
right axis deviation. Very good. Thank you. Next.
Thank you.
I think this will take us the last ECG, and we'll end it. Okay. So any takers for? We'll take this. Okay. Yeah. This ECG. Anyone? Okay, I'll take this. Last is for me. So we have standardization, not very clear. I'm assuming it's normal. After the standardization, we look at the technical errors. So AVR is okay. So we look at P wave. Okay, so here the P wave is positive in lead 2, 3, 1, and negative in AVR, and positive in V4, V5, V6. So it is sinus and origin. So once we know it is sinus and origin, so the rhythm is sinus. So we look at the regularity. So it is appearing grossly regular. So if it is regular rhythm, I can use the heart rate calculation. So 300, 150, 100, 75, 60, and a little less than 60. So between 50 and 60. So this is a sinus bradycardia that we have here. After the heart rate, we look at the intervals and axis. Very important here. You look at the PR interval appears normal, but whereas you look at the QT interval, I draw QT. I use leads best measurable is lead V5 and lead 2. So if I take lead 2, so you see the QT interval 1, 2, 3, 4, and 5. So I draw it somewhere at midway between 2.5 boxes. The T wave is crossing here, so I have essentially a prolonged QT interval. Apart from that, the QRST changes. So I have, before that we look at the axis. So one is positive, AVF is predominantly positive, so I have a normal axis. And coming to the QRST changes, there is physiological Q waves in 1 and AVL and V5, V6. There is no pathological Q waves. I see some RS complexes, RS in lead 3. That can be a normal variant. Apart from that, there is a normal R wave progression. And there is no obvious STT changes apart from a prolonged QT interval. So what this is basically what we are having is a normal sinus rhythm with a long QT. Okay, so this is what it is. Okay. So we come to the end of today's session. So I'll summarize the whole thing. So we have, whenever we look at the ECG, it is a graphical representation of the entire electrical activity. So we should know what each represents. So we have the electrophysiological system has its own implications. But coming to the interpretation, we look at the P wave, which represents atrial depolarization. Okay, someone asked me to explain the P wave origin. So if this is my atrium, so this is going to be the direction of lead 2. This is going to be my direction of lead AVL. This is going to be the direction of lead AVF. You should imagine this. Like the main reason why you should understand this is because of this orientation. So the direction is going to be like this as well as like this. The P wave is going to be positive in AVL and AVF and lead 2 as well. Okay. So the P wave, we define a normal sinus P wave as positive in 2, 3 AVF, negative in AVR, positive in V5, V6 with a 1:1 atrium to ventricular conduction. Second thing, we look at the PR interval. The normal is 3 to 5 small squares. The normal P wave is 2.5 in the limb leads and less than 1.5 in the precordial leads. Then the PR interval is 3 to 5 small squares. Then we look at the QRS. The QRS should be less than 3 small squares. Then we look at the T wave and some intervals that come. So we have the QT interval, which is 8 to 10 small squares, and the T wave, which is a slow rise and a slow fall. And the QT interval is usually half of the RR interval. And there is correction for QT. If QT prolonged, can lead to torsade. So when we are interpreting an ECG, we look at first at the standardization, then we look at the technical errors if there are any by predominantly looking at lead AVR. Then we look for the rhythm, regular versus irregular. Then we look at the rate. Then we calculate the axis. Then we look for chamber enlargements, some STT changes, and we look for ischemia or blocks. So that is the end of today's session. Okay, so next week we'll be having a session by Dr. Akshay sir on chamber enlargements and abnormal axis and how do you interpret an abnormal axis. Okay, we hope that it is useful, and if there are any queries, you can email us at this email, and this will be uploaded to YouTube, and we'll be sharing the PPT as well with all of you. Okay, which book to refer for revising today's class? You can start with maybe John Hampton. That's like a basic book. You can start there. Okay, and then there will be further. We can add on later. Okay. Okay. We'll end this session. Thank you, everyone.